welcome everyone. My name is Margaret Collins. I am a nephrologist and hypertension specialist. Followed an interesting course where I was in practice for 20 years, and I spent 16 of those 20 years as a hypertension specialist, thinking that I was fighting the cause of kidney disease. And I had my world rocked a little bit just a few years ago when I heard about APOL1-mediated kidney disease and found that it really changed my understanding of what I had been doing in my career. And now I'm lucky enough to be part of the effort to raise awareness about this really important disease, and I'm excited to share that with you. Of course, disclosure, I'm with Vertex Pharmaceuticals. That's a relatively recent thing, but we are excited to bring this story to you. This is a graph that I imagine many of you have seen. So this is looking at patients in the United States who are suffering kidney failure. Now, chronic kidney disease happens about the same as far as prevalence across populations, but African Americans progress to kidney failure 4 times as often as their white counterparts. It just so happens that this data range here from the USRDS, it also is my career. When I came out of nephrology fellowship in 2002 and first set foot in a dialysis unit, I have to admit, I was pretty shocked by what I saw there. The mere suffering of life on dialysis, the time constraints, the diet restrictions, access problems, hospitalizations, infections, and the mortality, 50% at 5 years. I felt like I was saying goodbye to somebody all the time. But I also really saw this disparity about how the fact that African Americans make up 13% of the American population, but 30% of those on dialysis. And the thing that bothered me more than that, or in addition to that, was that I felt that we often blamed patients for their disease. That we said, "Oh, you're, it was diet, or it was compliance, or you didn't do what you were supposed to, and that's why you have kidney disease." When I knew on an individual basis that patients really were trying, and this kidney failure was happening anyway. So I only lasted a few years in general nephrology before I decided to open a resistant hypertension clinic, because I felt like I needed to try to go a step back to the cause of this kidney failure. And so for 16 years, I fought hypertension, but along the lines, other people were fortunately asking larger questions. And in 2010, the APOL1 gene was discovered, and that would turn out to really change the way I viewed everything I had been doing in my career. So what was going on was, there were, in the 2000s, they did a number of genome-wide association studies and found that African Americans with a variety of chronic kidney disease seemed to have something in common on chromosome 22. And it became clear that that was the apolipoprotein L1 gene in 2010. But what was weird was that at this tip of the iceberg of understanding of APOL1, the 2 diseases that popped up were so different. So there was FSGS, which you all well know is often nephrotic syndrome, rapidly progressive kidney disease, as in particularly the brand of FSGS, that is the collapsing variant seen in HIV-associated nephropathy, is a really aggressive disease that I saw too much of when I was a fellow. But at the same time, what also appeared was run-of-the-mill hypertension attributed end-stage kidney disease, and that could not be a more different disease. But what they had in common is that people who carried variants of the APOL1 gene that arose in sub-Saharan Africa in the last 10,000 to 100,000 years, carrying 2 copies of those variants was associated with developing these diseases. Fast forward a little bit, particularly the FSGS associations with carrying 2 risk alleles became more obvious. It being a less subtle disease and being generally backed up by a biopsy, they were quickly able to see that people who carried 2 risk alleles were also the people who were suffering collapsing FSGS in the setting of COVID-19 nephropathy. They were also those who developed collapsing FSGS when they were given interferons for hepatitis C. That lupus nephritis had more severe features and more progressive to kidney failure. We saw associations with sickle nephropathy, membranous nephropathy, and a lot of the transplant failure that had been attributed to being a race issue was found to be associated with the genotype of the kidney being that of high-risk APOL1. So this really started to change the landscape. And meanwhile, Carl Skorecki in 2012 started to call hypertensive kidney disease hypertension misattributed kidney disease, in thinking that perhaps the brand of kidney disease that we thought was hypertension, but is associated with these two risk alleles, is actually something different. But across the board, it was clear that this is a progressive proteinuric kidney disease, and that if people who carry two risk alleles progress to kidney failure 9 to 12 years earlier than those without the risk variants. And if you think about that decade, that's important for soccer practices and career milestones. This is really a devastating disease that often turns up before age 50 or even before age 45, and sometimes in pediatric patients. And something really devastating it would be nice to understand better and to be able to do something about. In the last few years, the landscape has expanded even more in that this was considered a non-diabetic kidney disease because it seemed that the effects seemed to work outside of patients with diabetes. But the Million Veteran Program showed us that was not the case in 2023. And something that is not very well understood, but is particularly interesting to me, is the fact that fetal genotype, if you have a baby with two risk alleles, that predicts preeclampsia in pregnancy, which of course leads to preterm birth and low birth weight. And that becomes yet another arena where we have to wonder whether APOL1 makes a significant difference in a disease that often shows racial predilections, but perhaps the issue was at the level of genetics. So as a nephrologist in the last 20 years, I didn't have a lot of exciting things I could offer. It was ACE inhibitors and hoping for a preemptive transplant. But all of a sudden, with AMKD I think is a good example of what's changing in nephrology. Causal biology is becoming elucidated. You can make a diagnosis with a genetic test, and for the first time, there are agents in the pipeline that will allow participation of our patients in clinical trials to really be at the cutting edge of what's going on. And that is a brand new and exciting place to be. So let's go to the origins of AMKD, which is a fascinating story, which is very similar to that of malaria and sickle cell disease. So this was a coevolutionary arms race, specifically between humans and trypanosomal parasites. So apolipoprotein L1 is secreted by the liver, tucked into an HDL molecule, and is a watchdog in the bloodstream looking for parasites such as trypanosomes. And the way that works is if you have this trypanosome in your bloodstream, you see you've got this guy here, and they're your red blood cells. To a trypanosome, an HDL molecule just looks like trail mix. And so he comes along and decides he's going to endocytose this for a snack. And the way then the digestion happens is to fuse with this lysosome, which is just a little acid bath. But what the trypanosome doesn't know is that when APOL1 hits an acid environment, it becomes a dimer or a trimer, inserts itself into a plasma membrane, and becomes a monovalent cation channel. And when you see monovalent cations like sodium and potassium moving fast, water moving with them, very bad things happen to the trypanosome. So this is a brilliant sort of Trojan horse warfare against parasites, and really critical for humans surviving infection. But what happened was that in sub-Saharan Africa, particularly in Central and Western Africa, the trypanosomes developed resistance to the wild type of APOL1. And it just so happens that variants that arose serendipitously in the APOL1 gene turned out to be a lot better at killing these resistant trypanosomes. And so what happened was that people who didn't carry one of these risk alleles were dying at rapid rates of things like human African trypanosomiasis or African sleeping sickness. And people who carried one copy of the risk alleles were surviving. And so it makes sense that when you have strong selection for a trait, that as generations go by, eventually you have offspring who get a copy from each of their parents. And it is here that the unintended consequences happen. And that was the risk of APOL1-mediated kidney disease. So if you look in modern day world, if you look in Ghana, Nigeria, you find that the prevalence of people in the population who carry two risk alleles is very high. In the general population, it's around 30%, but there is a certain tribe in Nigeria, the Igbo, where 50% of the population carries two risk alleles. And just in the way life is strange, I actually spent two summers working in a hospital right in the middle of where that tribe resides. And I remember at the time noticing that people had so much hypertension, people who were too young, too healthy, and too thin and active to really have it. The machine that did chemistries in the hospital was broken when I was there, so I don't know if those folks had kidney disease. But in retrospect, it seems likely that this had something to do with it. Whereas if you look at Ethiopia, the trypanosomes that were resistant were not there, and so you really don't find this genotype. But what happened was that with the diaspora of the slave trade, of course, that drew heavily from Western Africa, and people found themselves in other parts of the world, and the G1 and G2 variants were along for that change. And many generations have gone by, and so people now who have Western African ancestry may not look like they have Western African ancestry and may not know it. Particularly in Brazil, many of the people turning out to have two copies of the risk alleles and APOL1-mediated kidney disease identify as white. So this is a great moment to stop and examine the fact that race is a social construct. It is not biological. And that this is a really terrific moment to stop and let biology remind society that genetic ancestry is very, very different than what you can draw conclusions about when you just look at the color of someone's skin. So if you look at what the impact is here, you've got in the United States, 13% of just the general healthy population carries two copies of the risk alleles. And among Hispanic Americans, who also tend to have a significant amount of Western African ancestry, the prevalence is about 2%. And what that translates into in the kidney failure population is a substantial portion of people on dialysis carrying two copies of the APOL1 risk alleles, particularly in the setting of non-diabetic kidney disease. 39% of African Americans with non-diabetic kidney failure carry two risk alleles. And as you can see, there are significant portions in each of these groups. And this is where that data came from about this 9 to 12-year acceleration of progression to kidney failure compared to people with kidney disease but without these risk alleles. So then in talking about the toxic gain of function that is the toxicity of the APOL1 gene, about how this works, what's interesting is that there's this broad possibility of phenotypes, because you have your underlying genotype, your two risk alleles, the underlying genetic background, an activating second hit that's critical for causing the disease, the individual cell expression within the kidney, and then you have multiple individual factors that are going to have an impact on what the phenotype is. And then we also have to look to social determinants of health. Everything from poverty to systemic racism to air pollution has an impact on the way this disease manifests. And for this reason, it is hidden in plain sight in our clinics, not just in nephrology, but in primary care and cardiology and OBGYN, because there are so many manifestations. So beginning with the second hit, this is an important point because only about 15% of people who carry two risk alleles are actually going to develop clinical kidney disease. I'll be the first to say this data is not terrific. As far as what the true lifetime risk is for people with the high-risk genotype, we need to study this more. But this is the best data we have. And the reason for this is the APOL1 gene is not expressed at baseline. It needs to be turned on by an activating second hit. And this is generally inflammatory. With those earliest recognized forms of AMKD, such as HIV-associated nephropathy, the high interferon states, high cytokine levels that you hear about, cytokine storm with COVID-19, that causes expression of the protein and presentation of the toxic effects in kidney cells. Similarly, in autoimmune disease, you see this for the very same reasons. And even the inflammatory state of hypoxia, such as, when you have microinfarcts with sickle events, you get hypoxia deep in the kidney, and that may be activating for APOL1. And 10 to 15% of people with sickle cell disease also have a APOL1 high-risk genotype, because again, we're talking about that same geography where an advantage against an infectious disease led to an unexpected disadvantage from the standpoint of a genetic disease. So this second hit needs to be better understood, but it's critical as far as clinical disease actually happening. So then if you look at expression of APOL1, it makes sense that you get a lot coming from the liver because that's the trypanosomal killing defense. But then if you look, you see that APOL1 is expressed in a number of other tissues, and we don't know what it does. For instance, there was a gentleman in India who developed very strange trypanosomal infections. And so someone looked at the sequence of his APOL1 genes, and it turned out he had two null mutations. And so had no working APOL1, and they weren't able to find anything about his kidneys or anything else that was abnormal. And so what this gene does when it's expressed in cells is still not clear. But in the kidney, it is well represented. It is expressed by podocytes, endothelial cells, and renal tubular cells. And so you can imagine, depending on where this is manifested, you could get very different presentations of disease. So this starts to explain this range. So if you look at this toxic gain of function, where this starts, at the beginning, the aspects of the protein were described with respect to its effect on the trypanosome. And the C-terminal region, where the G1 and G2 variants are different, it was actually named for the interaction with the trypanosome, which isn't very helpful when you're trying to figure out what's going on. But what G1 is two amino acid substitutions. G2 is a two amino acid deletion in the C-terminal portion. And over time, it's become a little clearer about what that does within kidney cells. So there are a number of toxic effects that the APOL1 variants seem to have. Mitochondrial dysfunction, endoplasmic reticular dysfunction, difficulty with cytoskeleton, which is particularly important for podocytes trying to make beautiful little foot processes. But what is particularly compelling is the very same monovalent cation channels that are the killing factors in trypanosomes being the mechanism of toxicity in kidney cells. So there was some really beautiful molecular modeling work done in the last few years that's given a much better sense of what the APOL1 protein is up to. It has 4 transmembrane regions, and that translates into a structure that looks like this, where you have those transmembrane regions anchoring the protein in a phospholipid bilayer. But what also is here in the C-terminus is a leucine zipper, which tells you that you're going to make oligomers. And it's not clear whether it's dimers or trimers, but I opted to draw it as dimers because it's a lot easier to see. So you have 2 of these molecules anchored in the membrane, which happens at acid pH. And when that happens, it lines up these alpha helical regions that become the lining of that monovalent cation pore. And what's even cooler about this is that there are a number of amino acids on the inner layer of this pore. And so at a pH of 6, which is what you get in the Golgi apparatus when this is first being developed, or in the trypanosome when it's fused with the lysosome, at this point, that's protonated, and that keeps the cation channel closed. But when you get to physiologic pH, those protons fall off, and it opens to become this cation channel. And what happens there with the variants is that the amino acid substitutions and deletions fall right in that region that is important for making these channels. And what that seems to do is it takes, instead of an 18-gauge needle, you got a 10-gauge needle, that the cation transport is enhanced through these channels. And that makes trypanosomal killing much more powerful, but it is also more toxic to the kidney cell. And it has become clear from in vitro studies that the influx of sodium and the efflux of potassium and then passive movement of calcium precedes lysis and programmed cell death in kidney cells. So what that looks like when you do this in the lab, in this podocyte, you have to apply something like interferon gamma as a second hit to get the protein expressed. And then you have the channels set up on the cell membrane. Potassium out, sodium in, calcium comes in passively, and this ionic disruption kicks off the inflammasome pathways. This is a distress signal. But the interleukins also act as yet another hit to increase expression of APOL1, which is even more destabilizing. And so you have dropout of podocytes from cell lysis and pyroptosis. And there's evidence, too, that this occurs in endothelial cells. It was kind of a neat mouse experiment that was done where a blue dye was circulated in mice who had mutations of APOL1 in endothelial cells. And the ones who carried the variants developed leakage of blue dye out into their ears through the blood vessels. So it was clear that those channels mattered as well in the endothelial cell. So what happens with the G1, G2 in this enhanced cation transport is that you lose the ability to kill trypanosomes, but then you also you improve the ability to kill trypanosomes, but then you also pay for that with renal cell toxicity. What's interesting is there's another co-mutation when we're talking about genetic background called PN264K, which is mitigating for this toxicity. It's a very common variant to be associated with G0, rarer with G2, never seen with G1. But when it's present, it has a mitigating effect both on the effects of trypanosomes and on renal cells. And what that ends up being clinically is if you have someone with high-risk genotype, if you look at their chances of developing FSGS, just one copy of PN264K appears to be protective against developing disease. Now, in the folks who had only G2, you see there were no cases of FSGS when PN264K was present. In mixed genotypes, then it was a mitigating factor. Interestingly, in the lab, when you put the PN264K into cells, it was protective against both G1 and G2, and it was specifically with respect to function of those monovalent cation channels, which was particularly interesting. It was looked at again in the setting of just chronic kidney disease, anywhere from stage 3 to end-stage kidney disease. And again, having one copy of PN264K mitigated risk. There's a lot of discussion going on right now about whether you should be genotyping for this off the bat and just how protective it is. And I think that's going to become something that's more and more available and will be part of the conversation, but a lot still to be learned about it. So sort of shifting gears, there were 3 months between when I decided to start working on APOL1 at Vertex and when I was wrapping up clinical practice and having to tell my patients that I was leaving practice, which was not easy. But it was also an opportunity to talk a lot about APOL1 and to make the terrible realization that it had been hidden in plain sight right under my nose, much more than I ever imagined. And so I want to take you through a few cases that I experienced during that time. So let's walk through clinic and start with Jerry. You're not supposed to have favorites, but Jerry was one of my all-time favorite patients. 61 years old now, though I had been seeing him for a number of years. And he had severe hypertension, just like his mother had. And his mother had had kidney failure that was attributed to that hypertension, and she was on dialysis in her 50s. He was obese, and he had a hard time with his CPAP machine because he had a lot of sinus congestion. He'd had multiple eye exams and other screens for diabetes. They did see bad hypertensive retinopathy, but he was never diabetic. And when he came to me initially, his creatinine was 1.4, and he had a gram of proteinuria, which is a little generous, but with all of this going on, I wasn't too concerned. And it took 6 drugs, and we're talking chlorthalidone, spironolactone, losartan, amlodipine, doxazosin, and bisoprolol, twice a day dosing of medications for years. And this man was A+. He always took his drugs, checked his blood pressure every day, and never missed an appointment. And he got back on his CPAP, he lost weight. And with that, his blood pressure got under control, his kidney function remained pretty stable, and his proteinuria went down almost to normal. But then I want to show you what happened over time. This is back quite a few years ago. He first came to me in 2008. And as we got things stabilized, he was going through time with blood pressure well controlled on those 6 drugs, starting at stage 2 kidney disease. And he had a blip several years later where his kidney function got worse and his proteinuria went up in the setting of being a pedestrian in a motor vehicle accident. And of course, here he had contrasted CT scans, he had nonsteroidals, there were all sorts of things going on. And so acute on chronic kidney disease for a little while wasn't too surprising. He settled back down, but never to where he had been before. And but his proteinuria did go back down to essentially normal. But then a few years later, you see this again with he had prolonged sciatica and a back surgery, a fingertip amputation, and then a bad episode of COVID. And it was here that things really changed. And it was also at about this time that I clued in to what APOL1 might be meaning for my patients. And as I sat down with him at our last clinic visit, this is where we were. And we were starting a 7th drug. His creatinine was 3.2. We had 2.2 grams of proteinuria. And as I thought about this in the setting of APOL1, I realized that this was never hypertensive kidney disease at all. And I was nervous for several reasons here. First of all, I just was overwhelmed by the fact that I felt like I had missed something big. But then also, I was a white physician talking to an African-American patient about to bring up the idea of genetic testing and about participating in a clinical trial. And despite the fact that I'd known him since 2008 and I had been invited to his wedding, I loved this man. Being so aware of the plight of African Americans with medical research, with healthcare, with the ways society has treated folks, there is this burden of mistrust. And I feared almost that I would look like I was trying to take advantage of him just by bringing up the topic. And fortunately, I was really wrong about that. He was really excited to hear this. He expressed just so much anxiety about feeling like he had done something that caused his kidney disease, that all of his efforts hadn't been good enough. And hearing that this might have been that there may have been a genetic cause for this, for him and for his mother as well, was actually really reassuring, even if there was nothing to do about it. And he was very excited about participating in this clinical trial. So as it turns out, another humbling moment, there was a clinical trial going on in my town. All I had to do was send him down the street, and sure enough, he was G1, G2. But what broke my heart is when they went to randomize him to start him in the trial, his GFR was 21 and the cutoff was 25. So he was not able to participate. And I talked to his current nephrologist several weeks ago, and I heard that his GFR is now 10. He qualified for this clinical trial back in 2014, but there was nothing there for him then. There was no genetic testing there then. There were no medications in the pipeline then. But this, I feel like, must not happen anymore. Not this way. So here we have the thing that gets a hypertension specialist out on the road teaching about AMKD is hypertensive misattributed kidney disease. Patients like his mother who were told they'd had kidney failure from hypertension have a 50-50 chance of carrying 2 risk alleles. And even though you definitely want to control hypertension because you don't want other reasons for insults to the kidney, controlling blood pressure does not change the course of AMKD because it's not hypertensive kidney disease. And that makes sense if you think about the mechanism. With hypertensive arterionephrosclerosis, this is an ischemic disease where you have systemic hypertension having thickened the walls of the afferent arteriole. You've got hyaline deposition, and you sort of starve out that glomerulus over time. Whereas with APOL1, this is cellular toxicity of the podocyte, the endothelial cell, the renal tubular cell. And the issue is not hypertension. And that was abundantly clear when you look retrospectively at the ASK trial, where you had African Americans with chronic kidney disease and hypertension with impeccable blood pressure control. And when you pull out the folks with 2 copies of the APOL1 risk variants, they zoom to those renal endpoints. Controlling the blood pressure didn't make a difference. So that is pretty earth-shattering. It changes the whole way you think about hypertension. Here's another thing that made me think differently. Della was another patient of mine, exceedingly complicated lady. She'd had a liver transplant because of metastases, and she was on tacrolimus for immunosuppression, which was causing chronic hyperkalemia. It was also exacerbating her hypertension, and she had advanced diabetes with diabetic retinopathy and likely nephropathy with nephrotic range proteinuria and kidney function that was going downhill. And as I was talking with her about APOL1, her daughter, I had never met her before, but she was visiting and was sitting and listening very intently. And as we were talking about this, she told me, I was diagnosed with FSGS when I was 17. I had a kidney biopsy, and I went through all these therapies that were miserable, and it didn't seem to make much difference. And I'm just wondering where my nephrologist has been, because it sounds to me like I should be tested for this. And we all sort of looked at each other, and I certainly had nothing to say, given that I had just recently clued into what APOL1 was about. But Tina is a smart cookie. She took matters into her own hands, and via 23andMe, she found out that she was G1G1, which makes the diagnosis of AMKD presenting as focal and segmental glomerulosclerosis. And for folks like Tina with 2 risk alleles and FSGS identifying as African American, this is exceedingly a common presentation. If you have an African American with a biopsy that comes back FSGS, 1/2 to 3/4 of them are going to carry 2 risk alleles. And this can present as idiopathic or as any of these variable presentations of FSGS. And across the board, as with many cases of genetic FSGS, there's poor response to immunosuppressive therapy, to the point that the KDIGO guidelines have called for avoiding immunosuppression in these patients. And, all of you know, as you treat patients with steroids, it's miserable. And I've heard from so many AMKD patients that they wish they'd gotten their diagnosis earlier so they could have been spared that. Well, so as we were thinking about Tina, we know that her genotype, at least half came from mom. And so she decided we needed to know about Della as well. And this is something I wouldn't have thought about because we had so many more explanations for Della's hypertension and diabetic and tacrolimus kidney disease. But look at that, G1, G2. And so then we have to consider that her kidney disease is super multifactorial. First of all, that it occurs alongside diabetes and that it can occur alongside multiple other causes of kidney disease. And what is seen as far as diabetes, as far back as the CRIC trial, this was a mixture of patients who were diabetic and non-diabetic as far as their cause of kidney disease, that again, folks with 2 risk alleles had much worse outcomes. And then Adriana Hung out of Vanderbilt did a really gigantic study back in 2023 using the Million Veterans Program and demonstrated that folks with diabetes who carry 2 risk alleles have a 30% increased chance of developing chronic kidney disease and an 80% chance of developing end-stage kidney disease once they have chronic kidney disease. So this becomes really important. So you see this, all of these risk ratios, your hazards and your odds for developing FSGS presentations, hypertensive presentations, diabetic presentations. And then there's also the question of transplant graft survival. And this is a murky little area, but it is definitely worth discussing because it's one of the places that's most compelling for genetic testing. I'm having trouble with there, sorry about that. So what is known from these studies, and in many of these studies, when the donor genotype was known, the recipient was not known. When recipient was known, donor wasn't known. When both were known, the studies were small and not replicated. But from what we know, it does appear that if you have a patient or a person who is high risk, who has the 2 risk alleles, who donates a kidney, which carries the 2 alleles, that kidney seems to be more likely to suffer failure with a hazard ratio of about 2. However, some of those do absolutely fine. They'll go on 5, 10 years. It's hard to know which ones are going to do poorly. But it is interesting when they looked at a series of biopsies of kidneys with 2 risk alleles versus 0 or 1, the ones that developed disease with 2 risk alleles looked an awful lot like recurrent AMKD. So the FSGS, collapsing FSGS, sort of hypertensive kidney disease sort of histology. When you look at that person who's donated a kidney, who now only has 1, and who carries the 2 risk alleles, that person started with a lower GFR than other donors in the first place, and her GFR goes downhill more rapidly than other donors who don't have the high-risk genotype. And that's a little bit scary when you think about someone who is themselves at risk for kidney disease. And yet, if you compare them to other people of the high-risk genotype, it's not that different. And so it's a little hard to know just how much risk is posed to someone of high-risk genotype who wants to give a kidney. And then a recipient who has 2 risk alleles and gets, for example, a G0 kidney, there doesn't seem to be any impact. And that's a significant thing to find out because there was a lot of thought that with all of the circulating APOL1 looking for parasites that it might attack a kidney. That doesn't seem to be the case. But there was a study where they found that the recipient genotype predicted not only loss of the graft, but T-cell mediated rejection. And again, this was one that hasn't been replicated yet. But what I found interesting is when they took mononuclear cells from those folks and looked at the APOL1 expression, CD4 and CD8 T cells, as well as natural killer cells, were pouring out APOL1. And of course, those are the main mediators for T-cell mediated rejection. So that's something that definitely needs looking at because that could really make a difference in how we understand the pathophysiology of graft failure and transplant. And more data is fortunately what we should get. The Apollo trial, which is being run by the NIH, should read out in the next year or 2. And in the meantime, the NKF working group has been very clear about offering genetic testing to any family member of a person with AMKD who wants to donate a kidney. So then we know that we have trypanosomal effects of APOL1. We've got renal effects of APOL1. It may be that we have immune aspects of APOL1, hard to say. And then we have the placenta. And the placental expression of APOL1 is actually in the trophoblast. The trophoblast is that outer layer of a 5 to 6 day old embryo, which becomes the placenta. And so I'm going to have you hold that thought as we go to our next case. So this is baby Sam and his parents, Obi and Anna. Obi and Anna are 26 and expecting their first child, both healthy, but as with many first pregnancies, Anna did develop preeclampsia at about 28 weeks, and it was hard to manage, and baby Sam had to be delivered at 31 weeks. So let's say, given that we know Obi is from Nigeria and Anna is from Puerto Rico, what if we were to find out that each of them carries a risk allele and that they had passed it along to baby Sam? Well, the first thing we know, of course, is that he's at risk for developing AMKD because of his genotype on the verge of, or on the range of about 15% risk. However, his genotype also predicted that preeclampsia that occurred in the pregnancy that produced him, with an odds ratio for developing preeclampsia for 2 risk alleles in the fetus being on the order of 2. And then also in those preeclamptic pregnancies, even when they make it to term, they frequently, these babies are born small for gestational age with odds ratios as much as 5.5. And that is an added important thing to consider when you think about Sam's long-term risk because of nephron endowment. As you well know, human nephron count varies widely, and this has to do a lot with gestational age because those glomeruli are developed in branching generations over about 10 weeks. And when that's interrupted, the absolute number of nephrons is fewer, and the quality of the ones that are developed can be impaired. And long-term, this in and of itself increases risk of hypertension, kidney disease, diabetes, and cardiovascular disease. And that's on top of the AMKD risk variants and what those hold. So here we've got these folks. We've got baby Sam, who is at risk for kidney disease and a number of other things, but there's nothing really to pinpoint that. We've got Tina, who just was diagnosed too early in the history of APOL1 for her nephrologist to consider genetic testing. I never would have considered AMKD and Della because there were so many other explanations, and for a long time, AMKD was considered a non-diabetic kidney disease. And most dramatically, we had Jerry with hypertensive misattributed kidney disease, who never had the chance to benefit from a definitive diagnosis and potentially being able to do something about it. So that's a little depressing. So I'd like to go to the good news about what's going on here. And that is, of course, we've got this, wide spectrum and ever increasing understanding of the disease that is associated with APOL1, and best of all, the causal biology that underlies it. And this can be diagnosed with a genetic test. And there are clinical trials, there are actual agents out there being investigated that may be able to be used for this gene. Instead of ACE inhibitor and a preemptive transplant, we're coming into an era where precision nephrology is actually really true, where nephrology is getting cool. And I never would have claimed that before. So as many of you probably know, KDIGO came out with in the new recommendations for chronic kidney disease management that if you have kidney disease of unknown etiology, that genetic testing should be part of the workup. And the National Kidney Foundation Working Group pointed out that 70% of pediatric chronic kidney disease and 10 to 20% of adult kidney disease is underpinned by a genetic abnormality. And so getting an answer and avoiding unnecessary diagnostics, avoiding unnecessary treatments is a good reason to get genetic testing even before precision therapies are available. And again, patients say over and over again that they just like to know, and they like to know it's not their fault, and they like to know for the sake of their families and their children. The other exciting thing is that you have this pipeline. If you go into clinicaltrials.gov and put in APOL1, all of these trials will pop up. And so here we have small molecule inhibitors of that monovalent cation channel, which appears to be toxic to renal cells. There are antisense oligonucleotides that will bind to messenger RNA and stop production of the APOL1 protein. And then baricitinib looks at reducing sort of the cytokine secondary hit that will turn on expression of the disease. Lots of activity going on right here, lots of things for your patients to be participating in. And get this is new this week. AMKD has ICD-10 codes. So if you have someone with 2 risk alleles and any manifestation of kidney disease, give them a name, give them a designation, give them an ICD-10 code. And if they have a family member with 2 risk alleles and any manifestation of kidney disease, that's got a code as well. And this is a chance finally to track folks, to understand the natural history better, and to make sure that, that when interventions are available, that we can find these folks. So then the bad news, of course, is that despite all of the terrific stuff that's going on, none of it matters if we don't find the disease. And we know the recommendations only suggest that people are sent to the nephrologist with a GFR of 60 or less. A 35-year-old with AMKD and a GFR of 60 is a disaster. That is so late to have been discovered. And we know that that is early compared to what usually happens, that frequently people reach nephrology only just before they start dialysis. The other issue, of course, is by definition, 100% of people with AMKD are of African ancestry. And in this country, that's associated with a lot of unfortunate situations, everything from poverty to systemic racism, social determinants of health that directly get in the way of early detection of kidney disease and get in the way of honest conversations that make genetic testing and participating in clinical trials seem like things that are safe to do. So there's a lot of work to be done. And so the work that needs to be done really starts with awareness. And I'm preaching to the choir here, particularly about proteinuria screening. Proteinuria is one of the earliest signs of AMKD. And so if we can get our counterparts to screen for proteinuria, we're more likely to catch that. Especially the new PREVENT calculator for cardiovascular disease risk assessment. Albuminuria is one of the things that is assessed with that. And I'm hoping that as our colleagues in cardiology and primary care pick that up, that we're going to start to find APOL1 as well. And so have a very low threshold to go through with genetic testing. It is becoming increasingly available from a number of sources. And when you do find AMKD, absolutely positively code it and look for a clinical trial for your patients, because our folks are hidden in plain sight and they can look so many different ways. There is no doctor who is irrelevant when it comes to finding that first manifestation of APOL1. And so if we can alert our village, make sure that your communities know about this, your primary care colleagues, your cardiology colleagues, your OB colleagues, your ER colleagues, and just to spare no one the news, because there is so much hope and so much promise for folks who have not had that before now. So that is all that I had for you. I'm delighted to take some questions. And also, I'd love to hear about your experiences and what you have seen yourselves with APOL1-mediated kidney disease. And I thank you for your time.
Excellent. Thank you so much, Dr. Collins. Several questions came up, very insightful and very promising time for management and diagnosis of AMKD. And the sun is on the horizon, so to speak, to come up, and we have finally something soon. Few questions. So there is a question about which kidney donors should be tested for APOL1 gene? So, period. And I would like add to this question also the notion that the study that you you referenced from the H3 African Registry Network study that showed that in the past, we thought the high risk is only when we have both alleles affected, but it turns out that a single allele also conveys some risk for kidney disease. So now that we know that, which patients should be tested, whether donors, specifically in this question, but I would expand it out to even non-donors, and then to go to the specific question of what to do with that if it is a donor.
Thank you. Fantastic questions. And of course, the NKF working group was a Delphi consensus where they sat down and talked about all of the things that you have to think about with genetic testing. And there was not agreement among everyone. It was a majority rule. As far as the closest things for guidelines, they were very clear in saying that anybody who is a family member of someone who has AMKD and wants to donate a kidney should receive genetic testing. I know talking with transplant physicians that most centers are screening for it liberally. And it comes down to, the conversations with your patients. I feel they have the right to know everything that might have an impact on the risk to them as a donor, the risk to them as a recipient, and that genetic testing is becoming more and more important. Then, of course, I see in big bold type here about APOL1 genotyping is incomplete without checking the M1 modifier. In the setting of manifested kidney disease, obviously something is already happening there. And the evidence for PN264K is that it is mitigating, not that it is neutralizing. That's not clear. And so it's an important data point, but it's one that still needs it still needs a lot of data. But in the setting of this transplant situation, if you had someone who was a high-risk patient wanting to donate to their family member, and you could tell them that they had the PN264K variant, and so their chances of getting kidney disease themselves were so much less, and maybe that kidney that they're donating even is protected. I think that really does matter. I think that getting PN264K in the setting of transplant makes a lot of sense. As far as the single allele disease, boy, is that the big question. Even as far back early on in the studies of AMKD as HIV-associated nephropathy, there was disease associated with a single allele. And if you look long-term with people with HIV-associated nephropathy and the risk alleles, the people with one risk allele tend to develop kidney disease after that 1 decade mark. And you wonder, what is it? Is there a threshold for the second hit? What does it take to get disease with a single risk allele? But the H3 Africa study that came out last year was beautifully done and showed that for FSGS, the hazard ratio was, or the risk ratio was about 1.8 for FSGS when you have 2 risk alleles, and about 1.6 with 1 risk allele. And in Africa, I mean, I know when I was working in ECHU, when people came in, you treated them for malaria first because you knew they had that, and then you found out why they came to the hospital. And so there was sort of a constant hum of an inflammatory state because of infectious disease. So you could imagine that maybe what was happening there in Africa with that study had a higher background of inflammatory stimulus of APOL1 expression. So it's just not known yet, but I would say absolutely we have to watch these folks with 1 risk allele, and we cannot begin to say that they don't get disease.
Thank you. And then there's one more question, and perhaps the last question here is, APOL1-mediated kidney disease is phenotypically very heterogeneous. It can present with florid proteinuria, acute renal failure, mild proteinuria, or maybe even no proteinuria, hypertension. So we have now a young patient of African ancestry. And let's go through the two different scenarios that we often see. One is, and that's a question by Dr. McCarthy, is also about how do we screen, how would you go about screening in a young patient with hypertension? No proteinuria, no obvious kidney disease, but just hypertension. And then perhaps another scenario that we also see is also a young patient with mild proteinuria, no hypertension. Something that in the past we would have said, proteinuria of 0.4 gram, and no one would have worried about it. But now we know the pathology possibly and potentially opportunity to clinical trial enrollment. And then the third one is like full-blown nephrotic syndrome, a patient presenting. So how do you how to go about diagnosing and screening these three scenarios?
That's a great question. I think, all of those, I think you could make an argument to do genetic testing, especially because there are plenty of clinical trials that are looking at, there are ones out there looking for low degrees of proteinuria. There are ones looking for massive degrees of proteinuria, various amounts of reduced kidney function. as a hypertension specialist, I found there were very few of my hypertensive patients that didn't turn up with proteinuria at some point, even if it was microalbuminuria or their GFR wasn't slightly reduced. I think the only thing we have to worry about with genetic testing is testing before there's any manifestation of disease, because only 15% of people are going to develop clinical disease with the risk types. There's no preventive therapy, and it can become toxic information as far as anxiety, as far as insurance, things like that. But for anybody who's manifesting any inkling of kidney disease, I wouldn't hesitate to do the genetic test.
Including hypertension?
I would say I'd still hold out for a little bit of proteinuria or a little bit of a reduction in kidney function. But again, when in all those years taking care of folks with hypertension, it was rare that I had someone who didn't have a little bit of manifestation of that with their kidney disease. I mean, with their hypertension.
Thank you. And now you have someone who has minimal degree of proteinuria. What genetic testing do you send them for? Do you send them for just APOL1, or do you send them for the CKD panel that includes 300 plus?
Yes, also a great question. It's nice that we have the option for both. And I suppose a lot of that has to do with the physician's preference and the patient's preference. It's certainly the panel. There are a lot of surprises on the panel. I'm sure you all have done tests and been surprised, for one thing, how much Alports is out there all of a sudden by doing a genetic test. But also a lot of providers are not keen to have to wade through that, the VUSs and all the other surprises that you find, and would rather just ask a simple question and get a simple answer. And so I think the preference right now is a perfectly reasonable way to make that decision. And the genetic counseling is hard to come by. There are a number of programs where that's built in, which is nice. Arcana, Natera, LabCorp have those options. But if you don't have access to a genetic counselor, you may not want all of the information of a gigantic panel. But I'm guessing that as time goes on, we're going to gravitate more toward throwing the panel first time when you've got someone with kidney disease, just like we get compliments or an ANA that we're going to do this panel.
Great. Thank you so much. Again, thank you, Dr. Collins. I also want to take the opportunity to make a plug for the Embark Awareness Initiative. So the Embark Awareness Initiative stands for Early Measures in Black African Americans to Raise Awareness About Kidney Diseases. And basically, GlomCon is organizing these events. We are going into communities. We have been in Atlanta, Philadelphia, Chicago, Nashville, LA, and basically going from community to community across the states to educate about kidney diseases, APOL1-mediated kidney disease, but all underdiagnosed and unrecognized kidney disorders in underserved communities, African American communities, provide test screening opportunity, testing, and follow up through local nephrologists there within the communities to see these patients. So I shared the link in the website, Embark Awareness. Take a look if there are events in your city, in your town coming up. Next up is in Chicago. And then please feel free to refer your patients there, send them there to get some kidney disease education. And if you are interested in participating as a volunteer, as a clinician, we would greatly welcome and appreciate that. Okay.
I echo that. Maurice Madden is doing fantastic work with that. Really, really cool.
Yes, great. Thank you.